In this video, we will present the physics of achieving post-free distraction during supine hip arthroscopy. The first case example is demonstrating supine left hip arthroscopy on one company's proprietary bed with a pink friction pad. Note the bed is positioned flat without any Trendelenburg. Slack is first removed from the operative leg with a gentle longitudinal pull to ensure the knee is fully extended without distracting the hip joint. After cleaning the skin, an air arthrogram is performed with the sterile 17-gauge spinal needle that is used to enter the hip capsule through an anterior lateral portal using fluoroscopic guidance. A small amount of air is injected to confirm intra-articular positioning. Roughly 15 to 25 milliliters of air is then injected into the hip joint to provide positive pressure and to break the suction seal. Fine traction can then be utilized to distract the hip joint, and the surgeon may proceed with standard hip arthroscopy. In the second case example, a second company's proprietary post-free surgical table is utilized. The anterior superior iliac spine is palpated, and a 17-gauge spinal needle is passed using fluoroscopic guidance into the hip joint. Once the needle position is confirmed, an air arthrogram is performed. Successful dissection of the hip joint can be visualized on live fluoroscopy. At this point, fine traction can be applied to easily distract the hip joint. With increasing volume of air injected into the hip joint, further femoral head translation can be visualized on live fluoroscopy. In addition to achieving post-free distraction of the hip joint, there are two further benefits of this proprietary table. There is a force gauge that allows the surgeon to directly measure the force utilized to distract the hip joint, as shown here. And there is a level that allows the bed Trendelenburg angle to be measured, and that is shown here. Precise joint distraction can be measured by placing a radio-opaque calibration ball of diameter 25.4 millimeters into the fluoroscopy field in the coronal plane of the hip joint. Lastly, femoral head translation can be seen with increasing volume of air during the air arthrogram. This may represent a patient's symptoms of instability or microinstability. In conclusion, we will review some technical pearls to achieve greater distraction. The operative bed surface is covered with a disposable high coefficient of static friction pad. Increased degrees of bed Trendelenburg are needed for hips that are more resistant to distraction. The force necessary to break the labral suction seal can be significantly reduced with an air arthrogram. The force necessary to gain further hip joint distraction upon entry can be significantly reduced with an interportal capsulotomy. Complete neuromuscular blockade and muscle relaxation is critical for distraction. The patient's body weight, although an unmodifiable variable, does play a role. Using a postless approach requires the patient's body weight to compress against the friction pad and engage its surface, permitting distraction. Heavier patients may be easier to distract. Lastly, this free body diagram demonstrates the forces involved during postless hip arthroscopy. The combination of gravitational forces achieved through Trendelenburg positioning, friction forces achieved through a friction pad, and an air arthrogram for venting of the hip joint allow for sufficient traction forces on the operative leg to distract the hip joint.